Om Shri Manjunataya Namaha. Om Shri Dhanvantare Namaha. Good morning everyone and welcome to today's session on Shrota Vikara. I would like to call upon Dr. Mudhar Sharma sir, Professor Emeritus, Department of Shalyatantra, SDMC Udupi to take over the session. Welcome sir.
In the Rasavaha Hridroga, the next part is about the Hridroga. Hridroga is produced due to involvement of the rasa according to Sushruta. Vegaghata, Ushna, Ruksha, Annehi, Atimatropasevidehi, Viruddha, Adhyashana, Ajirnehi, Asatnishcham, Bhojanihi, Dushaitva, Rasam, Doshaha, because of the involvement of the rasa. Vigunaha Hridayam Gataha, Kuruvanti Hridaya Badham, Hridrogantam Pratakshare. Due to the abnormalities related to the food and then the other lifestyle conditions, the rasa gets affected. That produces the discomfort or disturbance of the functions of the hridaya, and that's how the hridroga is produced. And the other causes of the hridroga are startasya nishwasa vinigrahena hridroga moha athavapi gulmaha, due to sudden suppression of the exercise. Now, once you do the exercise, you will have a breathlessness, but that breathlessness, if it is suppressed, that also can result in the hridroga. And the hridroga is categorized as 5 types according to the Samhitas. Atyushna Guruvarna Kashaya Tikta Shrava Abhigata Adhyashara Prasangehi Sanjitehi Sanjita Sanchintanihi Sanchintanihi, due to the excess of thought process or stress. Vega Vigadhanesha Sudameha Panchavidha Pradishtaha. 5 types of them are there. As per the current physiology, the risks for cardiac pathology, etiological factors for the cardiac diseases, particularly coronary, even including the other cardiac pathologies, the most important cause is considered to be the atherosclerosis or the atherothrombosis, the clot formation in the blood vessels or the abnormality of blood vessels. And the causes are many, and the causes again are categorized into 2 categories: traditional risk factors and the non-traditional risk factors. Traditional risk factors like the age, later half of the life, above 50, there is a gradual risk of the developing these conditions, and the age is around 45 years for men and above 55 for the women. Then a family history of premature coronary artery disease also is one of the causes or risk factors. Diabetes, smoking, hypertension, dyslipidemia, obesity or lack of exercise, and the premature family history of coronary artery diseases. These are the other causes of other risk factors of cardiac disorders, specifically coronary. Non-traditional conditions like abnormal ankle brachial index, that's where the patient would have an abnormality of the blood supply over the area. Ankle brachial index, and then atherosclerosis is one part which we will discuss in the coming session about the Rasavaha Hridrogas. And the conditions of any chronic inflammation, abnormalities of vitamin metabolism or amino acid metabolism like homocysteine, and patients who have the microalbuminuria as a result of hypertension or renal pathologies, metabolic syndromes, renal diseases, calcium. One important is excess of calcium in the body also is a cause for the cardiac diseases. Patients who have a chronic inflammatory disorders of any sort, where the CRP is raised or fibrinogen level is raised. HIV infections also can result increase the risk of coronary diseases. As far as the detailed causes of the coronary diseases, particularly ischemic heart diseases, are concerned, dietary risks, high systolic blood pressure are the 2 major issues. Then air pollution, total cholesterol level, tobacco, then body mass index, obesity, and sugar levels. These are the other high index causes. The other causes for the cardiac disorders in general, not only about the ischemic diseases, are mainly the junk food. Eating fast food, junk food can produce abnormalities of different sorts of the metabolism, and as per the data statistics, quite important, those who visit that fast food center and then eat pizza, gizza and so on, all that fast food, remember this, as per the data, If you eat 4 times or more per week, there is 80% increase in the risk as such. 2 to 3 times a week, the risk is considered calculated to be a 50% high risk as such. And the once in a week, every Sunday going to that also increases the risk by 20% as such. So fast food is considered as one of the quite important, or junk food is considered one of the quite important preventable cause for the cardiac pathology, and that's exactly what's mentioned by Sushudeva Ati Ushna Gurvana Kashaya Rasas. Then the other is quite important, very crucial issue in related to the cardiac functions are the physical activity. The persons who have a sedentary lifestyle, who do not do any regular exercise, the risks are 59% risk as such of developing cardiac pathology. Whereas those who do regular and rigorous exercises, they have only 14% risk of that. And that's exactly what's mentioned as a Shandasya Nishwasa Vinigrahena. Then, as far as the data is concerned, the cardiovascular disorders are the largest causes of death in India. As per the million death in India, after out of 1 million, 20.3% of males and 16.9% of the females, the cause is a cardiovascular. Other diseases come in the other gradual courses of the causes of the disease as per the Register General of India 2009 data. Then the cardiovascular disability adjusted lifestyle throughout the globe. Now this is about the causes and the risk factors and the total affected life factors also, which can affect the quality of life. There again, the dietary risks constitute the most important causes of the cardiovascular disability. That's how the quite important issue. As far as the other important factors now is about the incidence of the age factor in the cardiovascular disorders. Incidence of the age factors, like in India particularly, from 2010 to 2015, the data is available. The important is below 30 years of age, younger age patients, they are now developing more of these cardiovascular pathology. 2010, it was 8.3 points, like out of 78 these million adults, like, and in 2015 it has been raised to the 20.5 units as such. So that's a raise in 27% from 2010 to 15. But the latest, maybe currently the latest 23-24 data is not yet available. But if you see the data, probably this incidence may be much more higher. Patients of younger age, they are developing coronary diseases now more frequently compared to the previous years, and the reason is supposed to be the lifestyle factors as such. Anyway, that's about the issue, and hence in general about the cardiac pathology, the prevention of the cardiac pathology according to Ayurveda and in general, that whatever is suggested throughout the globe is same. Hitahara upayogah eka eva purusha vruddhikaro bhavati ahitaro upayogah punarvyadi nimittamti. Or what Charaka says, Naro hitahara vihara sevi samikshakari vishesho saktah data samaha satyaparakshamaman aptopasevi cha bhavati arogah matihi vachah karma sukhanupandam sattvam vidheyam vishudata shuddhihi jnanam tapah tatparata yoge yasyastitam nanupadanti rogaha. Particularly, these are absolutely true in case of the cardiac disorder, like having a healthy lifestyle and the consumption of a hita ahara, that's something which is suitable for the body, and samikshakari, those who will be assessing the surroundings around and assessing your lifestyle regularly, and self-correction is done, and who are not indulged in many of these aberrations of the interest. Vishesha Sakta is aberrated lifestyle, and data samaha, those who have a very equitable social life in the sense sharing their assets with the others also. Satyaparaha, who would not have a stress due to his vigilance to the truth as such. Kshamavan, who tolerates the stress others' behaviors. Aptopasevi, who has a good quality friends. These are the main important factors by which you can prevent the disease. Intellectual capacities, matihi vachaha karma sukhanubandham. Your intellectual capacities of regular study, regular observations, and the speech and activities also which are well controlled, and having a pleasant mind, Vishracha Buddhi, Jnanam, knowledge, Tapaha, study, regular study, Tatparatacha Yoga, Yoga Abhyasa. These are the important causes by which the disease can be prevented as such. Now, but the WHO says is about prevention of the cardiac diseases. 5 ways to prevent the cardiac diseases are the maintenance of the nutrition, exercise, prevention of the tobacco, social determinants where you will be the same data samaha where you will be sharing with others. Then of course aspirin is considered as one of the drugs as such. Compared to this, whatever is mentioned in Samhita is much more practical than otherwise. One of the important issue of very popular now in the present day situation is a diet which is suggested for prevention of the hypertension as well as prevention of the cardiac disease is the DASH, that's the diet against systemic hypertension. And that diet, among these lifestyle factors, the most important factor is daily physical activity. Then that food which contains whole grains, bread, etc., which has to be taken in larger quantities. Fruits, vegetables, the next step. Olive oil, fish, and the non-vegetarian food, others like eggs, cheese, etc. Sweets are the least. This should be the content pattern of the diet for us. That's the suggested one, which is now very popular. Anyway, that's in general about the introduction to the cardiac disorders. The next part of the cardiac disorders is about the congenital heart diseases. Congenital diseases again are quite huge, and going into detail of each of these congenital heart disease would be beyond the scope of our discussion, because that itself is a very huge topic. In general, the causes of the congenital disorders are either environmental factors which can be now prevented, like infections of the tubercular teratogens which are consumed in the form of either the food or the medicines, diseases of the mother or father, hemodynamics changes in the mother. Then genetic factors like chromosome structures and gene mutations, abnormal RNA, epigenetics, or polymorphisms of the genes are multiple causes. So the genetic factors come in a rather prominent manner in case of the congenital heart diseases, and the infected disorders also others. The importance of the gene counseling, genetic assessment prior to the conception now has gained a lot of value in prevention of the congenital heart diseases as such. Now, I will not go into the detail of congenital heart diseases in general, because from a routine clinical point of view, virtually there is very little to be done as a treatment, medical treatment from the congenital disease point of view. All that would be to prevent further this worsening of the cardiac functioning. But surgical treatment is the other way. In majority of the conditions, the surgical treatment is considered to be the best of the solution, and the incidence of the surgical intervention in children before a year of age, particularly in India, it's again the incidence is more frequent in the southern India, because the people now are more aware of it and the facilities also are available. Whereas in the northeast, the incidence of surgical intervention has become lesser, and that has resulted in certain differences in the morphology, these fatality as such. From a general physician's point of view, virtually, as I said, we have very little to do as far as the congenital heart disease management is concerned, and from Ayurvedic point of view, again there is a gross limitation from the Ayurvedic practice point of view, but definitely yes, as far as the prevention, the care of the pregnant during pregnancy, that prasuti charya, whether it will really help in reduction of the congenital heart disease or not is again one of the issues of interest, but probably that's one thing which can be tried and which would be definitely having some research value. In future it may have, but as far as the current issue is concerned, I do not have a very dependable data about whether it can be really prevented by the surgery or not, but I hope so that it will be. Then the other one responsibility to be early diagnosis, a careful auscultation of a child in the newborn as well as the later, and careful observation would be good enough to identify a congenital pathology. And the exact diagnosis of congenital heart pathology is again a high-tech job. It requires a high technology interventions, and hence it need to be assessed by the others. Then comes one of the area of real practical interest is congenital heart disease diagnosed in adulthood, which needs some discussion. That's one of the important issue. A congenital heart disease and the surgery and advantages of the surgery. A global data, which is in this again is from the publication which was published in 2020, so just 3 years back data. Maximum number of studies were done, and the follow-up was done with the advantages of surgery in adulthood. Now, one of the controversial issues, see, congenital heart disease identified at a younger age, below the age of 1 or 2 years. Almost all conditions are surgical, but there again, if the child has a sign of cyanosis or a retarded growth, significant cardiac insufficiency, in that condition the surgery has to be done as early as possible. In other conditions it could be discretionary, and in general the other advice is if the percentage of the exchange of blood is more than 30%, surgery is needed. That's about the guidelines, general guidelines. Whereas from the adult onset, like, or maybe not adult onset, adult diagnosed conditions, patients who are not diagnosed of the congenital heart disease in younger age, but at the adult age is diagnosed, that means the primarily that congenital heart disease is not a very severe issue which can affect the growth, and it may be diagnosed in the later part of the life due to either some investigations which were done that not directly related to the heart pathology, or maybe due to certain of the complications of the cardiac diseases. In such conditions, the question is whether the surgical intervention is really needed or not. So from that point of view, this data is quite important. A adult heart disease, a congenital heart disease diagnosed at adulthood is very important. Whether the patient can really be benefited by surgery or not, that's the primary issue. Based upon the data, large number of data, patients who have not undergone, never operated upon for the cardiac intervention, when they are diagnosed at the age of above 35, if the diagnosis is done at the age of above 35, then the survival period would be quite high. Survival numbers would be, total survival, cumulated survival would be high. Patients who have undergone surgery once, twice or thrice or fourth surgery, repeated surgeries, the survival, cumulative survival becomes lesser. Now this data doesn't mean that surgery is useless, that's not the idea. The issue is advice for surgery would be decided like based upon the possible complications which can occur without surgery. But in general, if a patient has survived with a congenital heart disease without any major issues till the age of around 30 or 40, that's definitely that patient can still continue to live on without any intervention for next 30 or 40 years, so that his life period would be within that average limits. But if the patient has certain complications which can affect the quality of life or the expected life period, in that condition interventions may be necessary. So the guideline has to be modified. Of course, present day situation, the guidelines, universal guidelines say the other way, that every patient has to be screened, and then there again one of the issue is the assessment of the possible risk of developing the later complications, and that's how it has to be treated. Anyway, that's about the basic guidelines. So in brief, that's about the congenital heart disease. So we will stop at that part. Now coming to the other diseases of the heart, as well as the other diseases of the heart, the most common diseases related to the heart are the ischemic heart disease, which constitutes around 46% of the issues. Then cerebrovascular diseases produced as a complication of the cardiac disorders like the thrombosis, embolism, thromboembolism, etc. That constitutes about 34% of the patients. So more than 80% of the patients whom we see with the cardiac pathology are mainly the ischemic heart disease and the cerebrovascular complications produced as a result of the heart disease. The other relatively minor conditions are the rheumatic heart disease, inflammatory heart disease like myocarditis and so on. Then hypertensive heart disease, which constitutes around 6%, then plus the other coronary disorders, other cardiovascular disorders of some significance like arrhythmias and other issues. So we will be focusing main on the coronary disorders now, which is a quite important issue. As far as the physiology of the coronary circulation, I think I will not waste much time on that part. The coronary circulation is one of the important issues which maintains the circulation or oxygenation of the cardiac muscles, and the coronary vessels are very delicate vessels, and if the perfusion is reduced, then these complications can progress, and it's not that the patient would have or any person would have the ischemia all of a sudden. The primary mild ischemia, which result in hypoperfusion, can result in simply a reduced exercise tolerance. The patient may not really feel the symptoms, but he feels that he is not able to do the same exercise as earlier. Then comes if it is continuing, it can result in metabolic disturbances where the patient would have improper oxygen concentrations or improper oxygen concentration in the coronary area, which again would be subclinical, which cannot be made out by clinical evidences. Patient may not have much of a clinical evidence. There again, the symptoms may be very mild, like there may not be any obvious signs of ischemia. The patient may still feel that he is not able to do the normal activities, general lethargy, etc. Then comes the diastolic dysfunction. If it continues further, then the patient would have a stagnation of the blood in the heart. So there is a tendency, if the ischemia continues to be there, then it can result in a diastolic dysfunction where the amount of the blood staying at the end of the systole would be the amount of the blood entering into the heart in the diastole would be lesser, or it can again consequently it can result in the systolic dysfunction where the amount of the blood ejected from the heart at the end of the systole also would be lesser, resulting in the stagnation of blood in the heart. A stagnation of the blood in the heart would produce more load on the heart muscles. So heart muscles now become temporarily hypertrophied. Maybe there is a tendency for the hypertrophy, or the heart muscles will show a significant impairment or cannot be able to cope up with the increased demand for the oxygenation. When you do the exercise, the oxygenation demand increases, but when the systolic and diastolic dysfunction occur, there could be a marked exercise intolerance. So till this stage, it will be only the exercise intolerance which could be the clinical symptoms, then otherwise there may not be any specific condition. All this is true in case of a chronic ischemia. The ECG changes would occur, ECG changes which are characteristic of the ischemia would occur only at the later stages. So by the time the ECG changes occur in a case of chronic ischemia, the ischemia seems to be quite pronounced and quite a long time, persisting for a long time. This is in case of a chronic ischemia condition. The chest pain as a symptom would occur much later, and by the time the patient would have a chest pain as a symptom, the amount of the ischemia would be always very high, and most of the times that results in a significant strain on the heart muscles. Either the heart muscles will be already strained and their capability would be reduced, or so on. And at the end stage, of course, there could be myocardial necrosis or infarction. But all these facts are true in case of a chronic ischemia, where the ischemia is progressive due to atherosclerosis. But occasionally, ischemia may occur due to an embolism, sudden blockage of the vessels, where these initial stages might be missed. The patient may have an infarction all of a sudden. The latent ischemia diagnosed with the ECG changes. Now, as far as our clinical conditions are concerned, when a patient comes to us, most of the times the diagnosis of an ischemia would occur only when the patient would have a preliminary symptoms like reduced exercise tolerance or so on, or maybe the ischemia may be diagnosed when you see the ECG, and particularly ECG changes only on exercise. Now, these patients who may, at times what happens is when the patient's ECG is done, the patient may have a normal ECG in the resting condition, but the ECG done in the exercise, after the exercise, can produce changes in the ST segment, which we again call as latent ischemia. So when I say latent ischemia, that may not have an obvious clinical signs of ischemia like chest pain and so on, but it could be only the exercise intolerance or such the mild symptoms where there could be early changes of ischemia, and there is no organic damage to the heart muscle significantly. Such causes may occur. In all such causes, from the clinical point of view, you will have to identify the primary causes. Most common primary cause could be a hypertension. Patients who have a hypertension, and the patient may need to be treated for the hypertension depending upon the level of blood pressure. As we have discussed earlier, in the previous classes, we have discussed about the principle of management of the hypertension, and that would be the better way. Or there could be like other causes like patient who have a chronic lung pathology also may have renal pathologies. So that's the issue. So the patient needs to get investigated, or you have to have a detailed clinical symptom. Suppose all those primary causes are ruled out, in such conditions, simple treatment would be, my prescription would be recommending pranayama regularly. Pranayama itself would be one of the most important game-changing techniques. It can, in early stages, at this stage, if the pranayama is practiced regularly, it can produce very huge, significant changes in the outcome. Course of the disease also can be modified. Then the prescription which usually would be prescribed would be Chandraprabha Arjunadishta. Virechana also could be one of the options in suitable cases, not causes, suitable cases. Virechana could be one of the cause condition. Then the usual vague symptoms which can produce the or make the diagnosis of cardiac ischemia in the next stage, like where there is a pronounced cardiac ischemia, where the patient may have the symptoms of cardiac pathology. The quite important is a large number of patients may have the symptoms which resemble that of gastroesophageal reflexes or esophageal motility disorders, peptic ulcers, gallstones could be the initial clinical symptoms in a patient of cardiac pathology. A ischemic heart disease by itself, the typical angina pain, would be seen only in a lesser number of patients, like 31% of the patients. Some of the patients may have chest wall syndromes like pain in the chest wall. So the most important issue is though in all our classical description, we describe about the angina as a clinical symptom of the cardiac ischemia. In a practical clinical field, angina is seen in around 31% of the patients based upon the clinical incidence of large number of patients. You have the reference over here. Whereas the gastroesophageal symptoms constitute the most common causes, common presentations, which need to be evaluated. Then the other rare clinical symptoms could be chest pain on the chest wall, pulmonary embolism, lung cancer could be the initial clinical symptoms, and so they are not much important issues as such. But most important is if a patient has a sweating, difficulty in breathing, sense of compression in the chest, irrespective of other symptoms, you have to confirm that, suspect that ischemia very strongly, and evaluation is absolutely necessary. Sweating, difficulty in breathing, and a sense of compression in the chest. These are the three salient characters which always confirm ischemia, almost confirm ischemia clinically, and that has to be assessed as such. That's the most important issue from the clinical point of view. ECG changes which are seen in the myocardial infarctions or myocardial ischemia would be again of different types. This again we have discussed when we discussed about the ECG earlier, but classically they are categorized into one ST changes myocardial infarction, non-ST changes MA as such without P wave inversion or T wave inversion, and non ST that ST changes MA with T wave inversion. These are the main three categories. ST inversion or ST elevation MA is the most significant issue from the clinical point of view. When you record the ECG, if the ECG changes, the ST in fact this segment is raised, then that's a classical clinical sign of the ischemia, and that would be considered as something like a acute condition which requires an immediate intervention. Non-ST changes, it could be the other way. It could be ischemic, there could be a severe acute crisis or not otherwise, and a T wave inversion with the ST changes would be, or non-ST changes would be suggestive of a chronic ischemia. That's the in general. The general, of course, there could be slight exceptions to that. So these conditions may not be an emergency, whereas ST elevation MA is considered to be an emergency as such. Once the patient has an ischemia or infarction, the death of the tissue occurs, the EC changes would be gradually changing as the condition changes. Like see, the acute injury, when the tissue is injured and the blood supply is lesser, then but there may not be an infarction. In that initial stages of the ischemia, the T waves become broadened, wide and tall, but there may not be any elevation of the ST. Once the tissue death occurs, if there is a evidence of some myocardial muscles dead as the dead tissue acts as a non-depolarizing structure in between, and hence the repolarization phase of the ventricles would be producing an extra current that results in the ST elevation. So ST elevation is suggestive of a death of the tissue, but gradually, suppose the patient survives and then you have treated the patient, then the dead tissue will become fibrosed or will be replaced by a fibrous tissue. In that condition, there will be a biphasic current formed, and that produces a T wave inversion. A T wave inversion with ST elevation suggests about a progressive changes from the dead tissue to the fibrous tissue, which is a living tissue. Then gradually, as it continues, all the dead tissue mass would be replaced by the living fibrous tissue. Then the ST segment becomes flattened, and the T wave pattern will remain as such. There is a possibility that there could be a complete normalization. Suppose the whole dead tissue is replaced by the normal tissue because of the relatively mild size of the infarction, then there could be a possibility of a complete normalization, but this is only a hypothetical, may not be seen in all patients. My suggestion or the importance of these ECG patterns suggesting about the stage of ischemia would be from the clinical point of view to show like which of the conditions have to be considered as emergency or not. The other way of assessing the risk factors of cardiac ischemia, or to confirm like which of the patient would need to have an immediate intervention or acute intensive care unit treatment, and which of the patient can be managed otherwise from the OPD level, would be based upon a popular scoring method, but is also called as a heart score, which is usually practiced in the emergency department. If the history is highly suspicious, 2 points, moderately suspicious, 1 point, non-suspicious history, then 0. If the ECG is significant with the ST changes, it's not only ST depression, either ST depression or elevation, 2 points. Non-specific repolarization, as I said, like the T wave inversion, etc., then 1 point. Then if it is normal, of course, 0 points. Age is above 65 years, 2 points. 45 to 65 years, 1 point. Less than 45 years, 0 point. But this now has to be changed, as I said about the possible incidence of the ischemia in case of the age factors is changing rapidly, and hence this fact has to be considered. Then the other risk factors like smoking, etc., smoking, diabetes, hypertension, If the risk factors are more than 3, like hypertension, diabetes, and the smoking habits or obesity, 2 points. 1 or 2 risk factors, 1 point. And the other criteria is the troponin level. If the troponin level is more than thrice the normal limit, then 2 points. If it is in between the normal and less than 3, it's 1 point. If it is normal, 0 points. Now, if you make the total score of, if it is 2.5%, 2.5% of the scores, like, then patient can be discharged. If the score point is around 20.3%, then the patient has to be admitted for clinical observation. If it is 72.7%, then patient has to be planned for invasive strategies, intensive care unit. This is one of the important criteria by which you can decide which of the patients are to be treated or can be treated management as such. The most important criteria by which you can predict the prognosis would be the troponin level, the cardiac enzyme level. So any patient with the suspected cardiac pathology, cardiac enzyme levels have to be studied, and in acute conditions, it is the troponin which is the most important issue, and creatine kinase, CKMB, is the other investigation which can help in predicting about the recovery phase. So if the cardiac troponin level is higher, the mortality of acute coronary pathology is very high, and the mortality within first 42 days. And this is the data. Lesser the troponin level at the time of examination, the risk level becomes lesser. Higher the troponin level, the risk is quite high, and that's one of the important criteria by which you can predict the risk as such. So that's in general when a patient comes with a suspected ischemia pathology, like where the patient has a chest pain as such. But again, if you go into the evaluation, it's not necessary that every patient would have a same course of the pathology. So ischemic conditions can be presented with the different sorts of presentations, and primarily they are categorized into 2 categories: ischemic pathology with an obstructive cardiac coronary disease, or ischemic pathology with a non-obstructive. Now, these days, in all patients of ischemia, suspected ischemia, angiography is done. If the angiography shows an obstruction, that is obviously an obstructive pathology, whereas non-obstructive pathologies, they are most important issues. And in fact, this angiography misses these non-obstructive conditions of ischemia. Non-obstructive pathologies could be of either a microvascular pathology angina, where the capillaries are obstructed, and the capillaries obstruction may not be identified with the angiography. Then the vasospastic angina, that's a spasm of the blood vessels which can occur either due to the stress or the other factors. Then a mixed, where there would be vasospasm as well as the microvascular pathologies together. These constitute a group of conditions which may not be identified by the angiography accurately. The prediction of the prognosis based upon the angiography would not be accurate in these conditions. Then, of course, you will have a group of patients who have ischemia due to non-cardiac pathology, like thyrotoxicosis, renal pathologies, etc., where the patient may have an angina or chest pain which could be seen. And the important is the non-obstructive disorders are the most important conditions where it could occur due to the inflammation of the vessels as such. So that's the one. Now, the non-obstructive cardiac disorders are the conditions which do not require an immediate intervention. Again, in an angiography, you may see that the blood vessels are either thinned out, but you will see the blood supply to the whole of the area, or there could be a remodeling. The area of the heart muscles may have sufficient blood supply again recover after an obstruction, which we may consider the non-obstructive pathologies. And these angiography findings can predict like which of the conditions require an intervention, like a bypass or a stent and so on. The interventional treatment is really required or not. But in these conditions where there is a non-obstructive pathology, definitely yes, intervention is not required. Direct intervention is not required, and they can be managed medically. And but the most troublesome factor in the clinical practice is this can be confirmed only after the investigations, and as angiography facilities are not available with our setup, most of the times the patients may have to be shifted to the other units, and hence you may not get an opportunity to treat. But there would be a good number of patients who have undergone angiography, and before they go for intervention they come for a second opinion. In that condition, definitely yes, these are the conditions where you can manage without the intervention. And the typical these ECG changes are either ST depression or ST depression with a slanting presentation where there would be a downstripping of that, or there could be an upstripping, like the ST elevation may be having that acute sharp image. This is usually seen in microvascular pathologies, which may not produce a sudden death risk. Right? Of course, cardiac functions could be affected. In these conditions, the treatment would be, of course, the patient may require a support of platelet aggregation inhibitor like ecosprin or maybe clopidogrel, or drugs like beta blockers or ACE inhibitors as antihypertensive drugs, they may be needed. Along with that, Prabhakaravati, Arjunarishta, graded exercise, diet and Virekana, if necessary Virekana, also could be producing a significant benefit, and the total outcome can be modified if the patient doesn't have any other complications as such. So that's how I treat the patients. Now, if the patient has an obstructive coronary disorder, that's the one of the other issues where the intervention would be absolutely necessary. Obstructive coronary vascular disorders, if you look at the angiogram, that angiogram would show a sudden obstruction and absence of the flow at a segment. Depending upon the intensity of that area, the pathology can be of severe issues, and the ECG changes are mainly of where you will see the gradual or maybe rapid changes in the ECG pattern. In the early stages, it could be the ST elevation, and later later on the ST elevation may result in a peak T wave as such. And if the same continues, and a very high risk could be when there is a arrhythmia. That arrhythmia would be always suggestive of a fatal issue, or rather fatal complication. If the ECG shows that these arrhythmias of either fibrillation or maybe ectopic beats, then that's a high risk condition, and immediate intervention is necessary. A life-threatening complication could occur in such conditions. So that's where you have to make out. Now, from the general clinical point of view, these acute myocardial infarctions or obstructive pathologies are categorized into 5 types. And of course, one is the myocardial injury, where there could be a mechanical injury to the heart muscles, which is right beyond the scope. The other 5 clinical types of myocardial infarctions are: the type 1 is where there is a spontaneous myocardial infarction as a result of ischemia due to primary coronary event such as plaque or rupture. There will be a pathology, and the scope for medical management from our clinical point of view is seen only type 1 and type 2 conditions. Type 2 is a myocardial infarction secondary to ischemia due to either increased oxygen demand or decreased supply, if the patient has a pulmonary pathologies and so on. That's the type 2 myocardial infarction. So type 1 myocardial infarctions and type 2 myocardial infarctions can be managed with medical management. Of course, I don't say that it may be possible only with Ayurvedic medicines. You may have to have the contemporary system medicine. Along with that, same Prabhakaravati, Arjunarishta, Chandraprabha can be helpful in reducing these conditions. And a large number of patients of that sort are treated in our regular clinical practice, where the patient may have the other complications like hypertension or pulmonary pathology. Along with that, ECG changes suggestive of the infarction. So type 1 and type 2 myocardial infarctions are medically manageable. The interventional treatment may not be required, can be managed without intervention as such. Whereas type 3 myocardial infarction is where the patient may have sudden unexpected cardiac death and suggestive of acute myocardial ischemia. Of course, that's one condition where it is beyond the scope of our medical treatment. Then type 4 myocardial infarction is a myocardial infarction associated with the interventions, patients who are undergoing surgical interventions like angiography or so on. So that's again beyond the scope of our regular medical treatment. Then type 5 is where the patient is myocardial infarction associated with the cardiac surgery. So these two, 4 and 5, are the conditions where our routine regular clinical practice may not have a scope, because it's when the patient is undergoing the process or as a result of the process, like a stent becoming thrombosed, which requires definitely a interventional approach and the patient can be treated. Whereas type 3 is a condition which can present with an acute complication and a fatal complication can occur. But the most difficult part would be to decide which type of the myocardial infarction is, and that requires all the clinical assessment. The primary difference between our approach in the type 1 and type 2 conditions, the type 1 where there could be a plaque rupture or erosion of the thrombosis. Now plaque rupture and thrombus erosion we will be discussing when we discuss about the blood vessel disorder later on. Usually in general the patient would be younger male patients who has maybe a high dyslipidemia or smoking habit, or patient may have may have undergone coronary treatment earlier, that angiography or angioplasty or so on, or even bypass techniques may have to be done. In such conditions, we will have to treat the patient. Now, to be more accurate, if at all the patient has all the investigations done, if the patients show the issue of involvement of the coronary intervention earlier, like coronary angiography or coronary bypass earlier, then in such conditions definitely yes, that patient can be managed from our point of view. Whereas a myocardial infarction of the second type 2 type, where there would be the other disease accompanying, like older patients, usually female, most of the times female, patient may have a heart failure, valvular disorders, hypertension, renal failure, or cancers, liver disease, depression, etc. These could be the other co-accompanying disorders which can produce these second type 2 conditions. The treatment involves the management of these other conditions as well as the same treatment for the coronary pathology. And usually the modern treatment would be the platelet aggregation inhibitors and antihypertensives are the drugs. From our point of view, it is the Prabhakar Oti Chandraprabha as such. That's about one set of the diseases. Now come from the Ayurvedic point of view, assessment of these diseases would be based upon the clinical presentation, which could be considered the dosha assessment of these conditions is the other issue, which we will discuss in the next session. So we will continue in the next session from the Ayurvedic assessment point of view of the Hridrogas. So if there are any questions, I will try to answer. Then no questions, so we will wind up.